It was with you as I see happy faces on the screen. I know this so serious well. It's a chance to hear from luminaries throughout all the subfields of data science, mostly on being relevant of cancer applications, and then also some others as well that are of interest, for example, digital twinning, which has had speakers not just in the medical domain, but also in terms of airplane design. It's also a chance there were really introduction of neuroscientists with fascinating stories to tell, in addition to those who are already well established from all fields. Chris Gibbons has started doing the introduction by Baihan. Like I was just saying, at least that I've had a chance to talk with Baihan at some length, that he's command many parts. Its interests range from the psychosocialization of large language models to cognitive isolations and walking to get hands. So, Chris, please show the introductory slide and take over.
Thank you, John. I do not have an introductory slide, I have to say, but I am. I will have the audience.
While you're speaking,
while I'm introduced, it's an absolute pleasure to introduce Baihan to the Data Science Forum. So Baihan graduated from Columbia University earlier this year with a PhD in computational neuroscience, but has worked for a long time in computational psychiatry group at IBM TJ Watson Research Center at Mount Sinai. Baihan has an unusually diverse set of experience and skills, and has qualifications, publications, and honors in fields as diverse as psychology, applied mathematics, linguistics, and natural language processing, computational systems biology, and data visualization. While pursuing his academic goals, Baihan spent time working as an AI scientist and researcher at Google Pets, at Amazon, and Microsoft, as well as at IBM. At Google, he won multiple Spot Awards and processed 7 patents. More recently, he's led the development of something called Safeguard GPT, a framework will be interesting to all of us that incorporates psychotherapy principles and reinforcement learning to mitigate some of the risks beginning to surface in recent noise as to chatbots. More recently, he's also received funding from the Department of Energy and their Insight program around work like the visual to GPT-4. Common to all of Baihan's work is innovation and strategic application of data science and artificial technologies in order to answer concrete problems in clinical research, and always directed towards near-term impact and patient outcomes and experiences. Baihan describes the AI from developed, empathetic, effective, neuro-inspired, neuro-symbolic. I've had the good frequency to meet with him recently to discuss our research and potential collaborations, and after doing so, I think I would definitely describe Baihan also as empathetic, effective, and neuro-inspired. Thank you so much for coming to talk to us, and we're all looking forward to hearing your insights.
So I will stop sharing, bring that on the series up. I love the title of the article, Towards Healthy AI and Large Language Models Meet Therapists Team.
Can everyone see my screen?
Yes.
Well, first of all, thank you, Chris, for the wonderful introduction, and also thank you, John and Baihan, for inviting me to this very popular data science forum in the area of Houston. So my name is Baihan, and as introduced, I'm currently at Columbia University and IBM Research. I think I cannot see the chat, so if you have any question that you want some answer right away, feel free to let me know. As many of you are either AI expert and also AI enthusiasts on how they are applied to the field of healthcare, I'm sure there is no introduction to how the AI and data science, especially supervised learning, has been transforming different areas of cancer research. So today I'm going to introduce something different, which is a different paradigm called reinforcement learning. It is a relatively less studied field of research in the healthcare domain. And unlike many systems which is powered by supervised learning, in reinforcement learning, we assume the data instead of as a static data set where we can train our model upon and deploy in our task, we assume those data to be coming sequentially, maybe in batches, maybe even in real time as streams. And I believe that this is connecting very well towards the long-term goal of towards having some sort of adaptive and continually learning health systems in the cancer research, where maybe we receive patients who follow up in sporadic time points, and how can we adapt our model towards them. And if we were doing digital twinning, as many of the people have interest in, can we also adapt our model towards new feedbacks of how new information coming in regarding the patient or the treatment outcome. So that is why that leads to my title of my talk, towards learning health system in cancer research, or reinforcement learning and real-time AI paradigm for patient care. Okay. First of all, I would like to thank my collaborators who I'm super fortunate to have worked with over the years. Without their guidance, support, and collaboration, I wouldn't have made it to today, to this prominent research seminar. I'm also going to present some research study who is done in collaboration with these amazing people. Okay, so first of all, I would like to briefly introduce my research. I am to create learning health system powered by one, which is intelligent agents. They are in digital twins of complex biological and cognitive and social systems, and based upon those intelligent agents, build therapeutic interface with real-time digital measurement in healthcare setting. So I also believe that many of my research is very well aligned with the very innovative initiative in the upcoming Institute for Data Science in Oncology, with many focusing area, especially in focus area 4, where Chris lives. So I will talk about what do I mean by learning health system, and also a few examples how they are given an outlook. So the learning health system is basically a long-term goal. How can we go from the data that we collect in clinical setting into the knowledge, and then distill those knowledge into clinical practice, and then using take action to change the practice, so on and so forth, to iteratively to collect better data. So this feedback loop of these three components also mimics in our more data-focused people point of view, where how do we collect better data, how can we build better model, and how can we also let those models to do better prediction in our clinical setting. So if we consider the entire thing to be a system that we would like to optimize, basically the practice to data flow will lead us to answer the question, how can we get better data? Because everything nowadays in clinical seems to be more data first. And when we translate the data to knowledge, basically we are finding better parameterization of this entire system. What is useful, what is interpretable, what we should take into account. And then how can we utilize those knowledge into our practice is kind of like in the machine learning question of how to do better optimization. How can we optimize the entire system so that it can maximize a certain reward function? In this case, will be some certain patient outcome. So my methodology that I have been developing over the years have been basically supporting this different type of question in learning health system. For instance, how to better characterize data. I've been developing different natural language processing, speech analytics, and also analyzing different type of neural data and vision data. Regarding how do we optimize those model systems, I use reinforcement learning, or the simpler case in the online or continual learning case, such that if you train certain model, it can either adapt towards its surrounding and learn through trials and error, or it can basically learn through batches of data. And I also have done research in human factors, which is intersection between psychology and also computer science. Basically, how can we understand what is really needs in the user side, and how can we build better human-computer interface upon them. And I have studied different data visualization as well as new media such as extended reality and VR. And regarding how to collect better data, my recent research has been focusing on how to utilize cheap sensors. By cheap sensors, I mean you don't need to rely on very expensive function imaging machine or some biological panels in order to get those data, but just having a cell phone or a recorder, you can already collect very cheap but potentially useful data to use them as digital traces, for instance. And also, I have been developing different spatial temporal modeling approach in the unsupervised learning domain. So, now I would also like to mention about digital twins, because I'm always curious about building mechanistic and personalized model of how our body functions as well as how our minds work. As I'm currently doing research in a neuroscience department in Columbia University, this has been my area of interest. So as you can see, here we are dealing with like very similar things as the learning health system we showed in the last page. We have data, we have model and prediction. But unlike building any computational model, my understanding to the digital twinning is that it is an entirely virtual replica of the model system, and it has to be very mechanistic so that we can simulate entirely virtually if we want to do certain intervention, what would happen next. And hopefully, through better and better data collection, we can make them more personalized in an individual level, so that we can not only do personalized prediction, but also generalize it towards new scenarios and future predictions. And in my area of interest, I also believe that those data also comes in with the research field of biology, biomedicine, and psychology. They gave us insights on what typical data would look like. And then the model, we usually use some sort of AI model as some mechanistic emulator. For the prediction, we basically bind it towards the specific healthcare domain that we are interested in. So we have this two-way loop, and I believe that the insights from literature, from the basic research science in computational biology, biomedicine, as well as in psychology or neuroscience, they gave us a universality of how to build digital twins. Well, on the healthcare domain, they gave us from a more individualized scale, where we're focusing on a particular population of patients, how they are performing, and how this patient differs from another patient. So in another way, that if we want to extend our AI system, which is merely a mechanistic emulator, into a generalized artificial general intelligence system, the basic science side of biology and psychology gave us insight on the learning rule and architecture of how a learning system would be, while the healthcare domain gave us a spectrum of how those intelligent agents will behave on a spectrum level. So combining both, we would have a both mechanistic and contextual learning health system that can have power to do computational generalization. By this, I mean that those model can be more foundational, and also after we train it, it can be applicable for different tasks instead of just tailored towards a particular task. So what does learning health system looks like in a cancer research? So here I'm outlining the core values that we are usually interested in solving in cancer research. They're solutions-based, and usually what we collect as feedback and what we measure as outcome. For instance, in the cancer prevention, we usually care about risk assessment and early detection of those cancer, and can we also engage the community in a large-scale value. And those feedback also involves those risk assessment, behavior tracking, and we would hope that cancer incidence from the start will be dropping, and we can detect the cancer from a very early stage. On the treatment aspect, we would want them to be individualized and also potentially have real-time decision support and measurement to support the clinicians. We would also want to engage the patients such that they can have follow-up in the program instead of dropping out through the entire treatment program. So we would like to build certain AI-based decision support system and have some sort of treatment guideline as well. Many feedbacks would be not only the treatment response by the clinicians' feedback, as well as patient-reported outcome, which is also an active research here in MD Anderson. So another area that I'm interested in is cancer survivorship. Because the cancer, I believe, although MD Anderson has a mission to make cancer history, with everybody's lifespan becoming bigger, older and older, eventually maybe most people will get some sort of cancer. And how do we recover from the cancer is a long story. So the importance of having a good quality of life after curing a cancer is as important as curing the cancer process itself. And also, many studies has also showcased the psychological effects of cancer survivors or during cancer treatment towards its family, and also through long-term from the developmental process of, say, a children who has gotten a cancer by itself. So those patient empowerment and survivorship care is also very important. So my area of research, I'm curious to solve the problem of these three areas in one, to identify how to measure these core values as matrix, and also how to build learnable, personalized therapeutic interface given those matrix, as well as how to learn and optimize from this feedback and outcome. So far, my past research has been supporting a subset of this entire table, and I believe I'm very interested to extending them more and also testing them in the clinical practice here in the cancer research. So let me give you a few examples. So these are very brief examples. Some I'll go into further details later on. So first of all, for the measurement, I will take this past research of mine on how to build a model-informed risk assessment of Zika virus outbreaks. So this is an epidemiology research. However, as we can see that the data source that we can collect it doesn't have to be just the clinical matrix that we are measuring, but also from other available data. For instance, from the temperature, from the government resource, and all those data. And if we can train an interpretable model upon them, we can have very high precision in predicting the forecasting how geographically spreading certain disease outbreaks will look like in the future. So similarly, if we translate this into a cancer type of problem, instead of having different geographically location, maybe that will be in a particular organs or some sort of spatial temporal modeling of the disease progression. And second, what would a personalized interface look like? So shown here is an example of we can train disorder-specific policies or AI companion for different type of patients, like for anxiety, depression, and schizophrenia, and for different type of therapeutic purposes. And then we can not only spread them, those model training into different type of disorders, we can also have those models to be trained and fine-tuned on particular patient, so that this model will interact with the patient from the second that the patient gets intake into the healthcare system of a particular hospital, and then all the way towards following up, so that basically if this is an AI companion for the patient, it will be adaptive better and better towards this particular patient. And I'm now also extending it into group therapy setting with collaborators in Mount Sinai, where, say, if you in a group therapy where there are different patients talking to multiple doctors, and I can have real-time analytics of each individual patient, and their patient-doctor relationship over time. So those are all enabled. Again, I'm not going into particular details in these example slides. Another example, just to showcase the complexity of problems in medical prescription, is this problem of government's policy prescription of non-pharmaceutical intervention plans. So in COVID, we have to balance two things. First, we want to make COVID cases to be as low as possible. Second, we also don't want the government to have a very high resource stringency, meaning that we don't want to, say, close down all the schools and have the education to drop, or close down all the shops and the economy will crash. Instead, we are doing these very complicated combinatorial optimization problems over time, and how can we optimize for a parental frontier of this multi-dimensional combinatorial optimization problem. So similar thing will happen in a cancer treatment. So for instance, if you're dealing with breast cancer, of course we wanted to remove the cancer tissue as much as possible, but also we would also like to care about the quality of life of them after the removal of the cancerous tissue. Maybe they value other quantities more, and how can we deal with those different values or different objective functions altogether, and in order to decide what the best treatment plans are. So those are algorithmically how complicated these things are. And third, how do we learn and optimize from this feedback? So I believe that reinforcement learning is a solution. So as a brief introduction of reinforcement learning, we have an agent. In this case, is an AI model or this learning system. It will take an action to the environment. In this case, the environment is an unknown distribution of how the patient will respond to a particular treatment or interaction from the doctors. And then after receiving this action, the environment will proceed, right? The patient will respond to the drug or not respond to the drug, but the state of its the therapeutic state of this particular patient has progressed to the next state, and it will reveal a feedback towards the AI agent as a reward. So and also the state will progress as I just introduced. And to translate the learning health problem into the reinforcement learning problem, when we consider how do we build a better data to knowledge flow, it's kind of like we're modeling the reward to understand what actually matters, what features is important. And when we want to distill the learned knowledge into the practice, we're optimizing the policy, meaning we are choosing the optimized way to behave in a particular way in order to maximize the final reward. In this case, is the patient outcome. And in order to better learn from the practice outcome towards how do we collect better data, we can have some sort of active learning or attention mechanism to pick the better data to collect in future rounds. Overall, I believe that reinforcement learning has a very big promises to the healthcare domain, because it can interact with not just the patient, but also the doctors, the policymaker, the family, and related ones. And then basically everything can be adaptive, and every agent can be also trained end-to-end as a compact system together to take into account the very complicated multi-objective combinatorial optimization problem shown earlier. Okay. So I'm going to focus my talk for this. Yes, please.
Hi, I hope you do. Go ahead.
Yes.
Fascinating. I hope you don't mind.
Yes.
Interruption. This may be something you would get to later, but let me put it on the table. At MD Anderson Department of Biostatistics, as well known as pioneer in Bayesian statistics, Bayesian optimizations, that armamentarium relates in some ways quite closely to the aims that you're discussing for reinforcement learning. At some point in the discussion, it doesn't have to be at the moment, I'd be really interested to hear, since there are statisticians from the department here as well, your thoughts on the two disciplines.
Thank you, John. I would be very interested to hear more discussions like afterward regarding a more Bayesian perspective on those problems. Indeed, what I'm presenting here is just from the reinforcement learning point of view. And many reinforcement learning algorithms are actually Bayesian, have a Bayesian assumption, and there are also a specific probability matching a type of algorithm that is just on the reinforcement learning aspect. But I would agree that many of the solutions can also be performed in the Bayesian inference point of view, and I'm happy to discuss more afterward.
Well,
Okay.
with explicit Bayesian formulation is within the RL framework.
Yeah, exactly. Yeah. Okay. So. Yeah, okay, so for the next part, I want to focus particularly in the psychological trait as a focus domain. It's been known that mental health is a global issue. 1 in 5 in US experience mental illness. And it is even more so in cancer patients as well as their caregiver and family member. And this type of psychological effect is very important for how they will engage in those treatment, how afterward their prognosis after a particular surgery or treatment, because there are also many psychosomatic effects, and basically it is a lifetime battle towards mental health as well. There are many anxiety, depression. They are also highly correlated with the cancer incidence. So I want to briefly mention the method domain currently in mental health. Existing approach, they usually use some sort of off-the-shelf solution. They are usually generic for similar problem. And in order to have some interpretation, you have to do post hoc interpretation. So this also includes, if you want to directly apply a GPT model for psychotherapy and all those kind, they are not trained particularly for this problem setting, and they might not have very reliable response. Well, our approach is more theory-driven. By theory, I mean from a neuroscience or psychiatry theory point of view, how can we build a model architecture from that? And it is tailored. Wait, I saw the meeting has been ended by the host. Is it the case or? Our approach is that it is also tailored to the emulated system that we're interested in. In neuroscience, it will be emulated how brain functions from different levels, and it should have one-to-one clinical implications. So what do I mean by that? So first of all, we use certain task-driven model which has some deep representation. It can be any deep neural network model, even some large language models or other type. And then we would like to have some one-to-one correspondence to some psychiatric correlates which have some sort of symbolic representations, so that later on when we can basically kind of like dissect a particular network as if we are doing a lobotomy of a particular brain region and we know what function it is. And again, it is also mapped to certain neural correlates, which is brain representation. And this can be done by doing representational comparison between different neuroimaging data with certain concepts that we manually parsed. So the good thing about this approach is that, first of all, we have a very useful predictive engine because deep learning is very powerful, it's very predictive. And also we have actionable and interpretable insight for the clinician to use afterward, after we train this entire model system, maybe as a digital twin or whatever things. So take the modeling a mind machine as an example. There are different scales of neuroscience inspiration, all the way from the minuscule level of genes and molecules towards the big level of personality to society level. And in between, there are neurons and networks and how they are connected. And if you want to map to the Mars 3 levels for modern day neural network, usually the focus of this have been upon the neuronal level, how they are connected as network, and also how they output things as functions or behaviors. My past research has been basically delve into different levels of the minds or the neural systems and try to model them separately. And there have been different applications to this type of neuroscience inspired algorithm into mental health, question answering, computer vision, game playing, even controlling the drones, satellite imaging, even detecting when an earthquake will happen, or speech recognition and all those input. So that showcased that the power of this type of neuro-inspired AI, they can do very well in machine tasks. And however, if you want to model them more closely towards how a brain actually functions, there are more challenges. For instance, we are sometimes missing the developmental and evolutionary timescales. And also there are different levels of subnetworks, and subnetworks also communicating with other subnetworks in other levels. And there are also adaptation and continual learning across the lifespan. How do we deal with them, right? And also, a modern day neural network model is not necessarily the best model to capture how a brain functions mechanistically, because many of the deep learning models have been relying on huge amount of data to train. They're vulnerable to adversarial attack, and usually you have to do ad hoc or manual network engineering, and the power resource consumption of such model is based just not the scale of our human brain, where it only runs on 20 watts. And also it can forget things and cannot generalize to new tasks. So I summarize for 3 key principles that I believe will be the most important one if we want to build a neuro-inspired algorithm for the healthcare setting. The first one is definitely attention mechanisms. Since our human brain or other biological system, they process information from enormous routes, and how do they filter out unnecessary information both externally and internally is a very interesting question to model. And secondly, I believe that the reinforcement learning mechanism should be the backbone of such digital twins, because it can not only learn from continuous input, it can also adapt to the learning process or the developmental process that humans are when they are growing up and also interacting with the world. And finally, I like the language because I believe language is a window to the mind and also intelligence, and also a gateway for ourselves to do intervention. Since language is how we communicate, it's how doctors and patients communicate with one another. If such model can also understand language, then we can have a better shot of interpreting such a model afterwards. So the example that I'm going to showcase is 2 examples. The first one is about reinforcement learning. How can they utilize biological priors to grounded by neuropsychiatry? And the second one is about natural language analytics with cognitive priors and how it can be helping us to do computational phenotyping and automatic annotations. So a brief recap of reinforcement learning, you already know that, but in the traditional RL setting, there are different reward parameters an agent learns when they are interacting with the environment. Those reward parameters may be how it is actually treating the current reward signal and how myopic it is through past information and other type of parameters for an agent to learn. But if you are given a particular reward parameters, meaning how an agent perceives the reward and uses the reward, but we are trying to learn the policy or how the agent does the decision by itself, and we are given an environment where we can test against, this is a traditional reinforcement learning setting. There is also an inverse reinforcement learning setting where we are given a policy or the historical trajectory of how an agent interacts with the world as well as its reward parameters. But we are curious about what the reward looks like in the environment. For instance, if maybe we already have experienced doctors, historical actions or treatment plans for cancer patient, for psychiatric patient, and we want to understand what is good practice from those experienced doctors' notes or doctors' practice. This is how we can use inverse reinforcement learning to learn for what actually counts as good, what counts as good in terms of, say, patient outcome or cancer survivorship. And we also have a behavioral modeling setting where we want to learn how a particular agent perceives different reward signal. So this is useful for particular psychiatric disorders where they are basically related to reward processing mechanisms in the brain. So, a brief recap on the neuroscience aspect. In our brain, we usually use some dopamine signaling that represents a bidirectional or positive and negative coding for prediction error signal. So this prediction error and value, they can actually drive behavior which are very important, like motivation, approach behavior, and action selection. And that actually can give rise to a wide spectrum of different types of psychiatric disorders. So, and those mental disorders, from an evolutionary psychiatry point of view, they are actually at extreme points where we live in a continuous spectrum of behavior. So it's similar to this argument of how everyone lives on a spectrum of neurodiversity, where certain particular individuals are neurodivergent and some are neurotypical. Similarly, if we consider all the behavior reward processing parameters living in this high-dimensional manifold, many mental disorder, maybe there's just extreme point in this spectrum. And as a result, somewhat less extreme version of this trait can be beneficial for certain environment. For instance, ADHD, they are very myopic to the historical data, so that a historical experience. So that's why they have fast switching. Maybe it's very good, evolutionary speaking, for flight and fight, right? And as an example. So that if we can model those disorder-related reward bias and place our digital twin on a spectrum, we can lead to better AI. And one mechanism will be the attention mechanisms. And as in the reward one, we already know there are some specificities. In attention, it is an anatomically separate structure from the processing system itself. And also there are two types of attention. One is a bottom-up approach or a more passive attention. And there are also some top-down active attention where higher level brain region tells lower level what to flag and what to filter out. And it has been shown that attention constrains and biases the reinforcement learning mechanism. And the reinforcement learning actually in turn shifts the focus of the attention. So it is a two-way thing. So here's an example how we can model both the external attention and also the internal attention of a brain. So we can have multiple level of hierarchical reinforcement learning agent that actually can select a particular subset of visual input to look like. So those can be useful because it has been shown that certain, say, autistic patient or other type, they are usually having, they pay attention to different things from neurotypical individuals. And that has been driven by different connectivities, which can be a case where when we have brain tumor and certain neurofunctional connectivity got disturbed, and in turn, those attention mechanisms will change in the brain. And there are also internal attention where maybe we select different brain regions to activate more than others. And as a result, we have some sort of routing mechanisms. And it has been shown that this type of model is very good at doing machine tasks. And so, but maybe we would also like to model the other way around, like we mentioned, the attention-driven award. So what do we mean by want the attention to capture? Do we want them to have the most utility or the group utility or basically having some performance and attention-driven mechanisms from different point of view? And another example would be a more passive attention. So shown here is a mechanism which is unsupervised attention mechanism. And this has been inspired by the neuronal firing assumption, which is contradicting to the Bayesian assumption in neuronal firing. So from the informational theoretical point of view, if a stimulus or the information feed into your sensory perception system is less regular, meaning that it is rare, then you have a higher firing rate. And this would happen not just in your sensory module, but also how different brain regions communicate with one another. So if we can model this type of regularity process across different brain regions, we can build better neural network algorithm to perform a wide variety of tasks. And due to the time's sake, I'm not going to go into detail, but you could also model saliencies in neuroscience and bake it into this type of model. It has been shown to be doing very good in different natural language tasks, game playing, and also other computer vision tasks, and so on and so forth. Okay, so back to the healthcare problem of modeling patient. So the previous example is just to showcase neuroscience-inspired AI algorithm can be very powerful for machine tasks. And I forgot to mention is that when I introduced the reinforcement learning, it is a full reinforcement learning problem. There are also two simplified versions. One is called multi-arm bandits, meaning that we just want to learn each particular action corresponds to which particular reward. But doing this action will not change any state. And the second one will be contextual bandits, where we are offered certain state information, which give you an context on whether a particular action is good or bad in particular case. While the full reinforcement learning problem, you can also change the state. And in order to better model the brain, because our brain, as I mentioned earlier, actually processes positive feedback and negative feedback, or the penalty versus reward, in entirely separate anatomical structure. So it will be more reasonable to process those reward signals in the positive and negative domain separately. However, when we are doing action, when we are doing decision making, we are constantly doing this type of balancing or trade-off process. So that's why that we would want to have a hybrid process of action selection process. So algorithmically speaking, that will be given us a two-stream mechanism for both the bandit scenario, the contextual bandit scenario, and also the reinforcement learning scenario to accommodate for both how you are perceiving the history of reward in the positive and negative domain, and how you are perceiving the current reward in the positive and negative domain. And the good thing about this is we can have two things. First of all, we can have them as mechanistic model where we can simply set those parameters based on clinical literature that we know. For instance, like Alzheimer's, they have a certain loss of appetite, so on and so forth. ADHD is very fast switching, so that's why they have very small weights and on the perception of historical data. And maybe chronic pain is very fearful about the negative input, so that's why it has a huge weight upon them. And another interesting thing will be to use Bayesian approach to do regression and find out those reward parameters from data. So if you have a patient to do a particular thing, then we can do diagnosis or monitoring of how your reward bias change over time. So we find out that the two-stream reinforcement learning outperform all baseline, all psychological tasks of human beings. And we can also see very interesting short-term and long-term behaviors of different type of mental agents, such as chronic pain or addiction. And we can also find that in game playing, some of the disordered agents can even do better than the baseline in many interesting settings as well. So due to time sake, I'm just going to show you an example of behaviorally how how they change the behaviors of the agent. If you look at the addiction, you see that it is fearless, right? It never avoids a ghost, but it only pursues the reward or pursues the dots or the foods. While the chronic pain is another extreme end where it is not interested in eating any dot as well. It only actually escapes when a ghost comes in, where it experiences fear. So although they all can survive internally in infinite time, but they actually behave quite differently. Okay, so I'm going to talk about the second part, which is the clinical instrument as linguistic references. Psychiatry is very complicated, and it has different, but also it is not as objective as other clinical studies. So that's why that people have been saying psychiatric research is in crisis, because it usually uses some sort of patient-reported, like self-reported questionnaires. And sometimes even you just talk a few words and they will give you a prescription. Unlike in many other clinical fields where you would have all kind of physiological measurements to be recorded. So as a result, the National Institute of Mental Health has been promoting this research domain criteria framework to move from diagnostic categories to functional domain. So can we actually have more data-driven and also more objective measurements of those different type of functional trait or symptoms of psychiatric disorders? And I would also like to introduce how can we utilize chip sensors to capture even more more granular features of those neuropsychological features. The example is the therapeutic alliance. The therapeutic alliance is the most important predictor of outcome of any type of psychotherapy. No matter you are cognitive behavior therapy or applied behavior analysis therapy or all kind, and also across different disorders. And it affects the patient's commitment to continue treatment, basically how engaged they are, and how likely they are accepting and following direction. It has been shown that if you have a stronger alliance, you will have the most amount of reduced symptom. And it usually has 3 scales. One is that whether or not the patient and doctor develop a very strong bonds. The second, whether or not you and doctor agree upon the mutual goal of the entire treatment program, and also whether you are on the same page of all the subtasks. And there are also some temporal and relational resolution as well. There are alliance between the children with their parents, children with the caregiver, children with the therapist, and also if you have strengthening alliance, it is even more indicative of the success of a particular treatment program or something like that. And I want to mention that it is very important, especially for the cancer patient, because the cancer patient, like I mentioned earlier, is a very long-term process, and sometimes there are different stages, and it has a more complicated relational structures, as in the bottom left, right? You are interacting with social workers, oncologists, and even more so in pediatric care, where you're working with your parents and caregivers and everyone. And also different phases of cancer treatment also have different emphasis on different scales of therapeutic alliance, and also how can we engage in effective communication across the entire process, right? Yes.
Before you go on,
yes.
I may comment. Others
Yes.
can within reason interrupt briefly as well. And you have come to the institution that is more attuned to these issues and pays more attention to them than any other I've ever encountered. With the kinds of notions of alliance that you're talking about, the attention to the psychosocial as part of not just the survivorship programs, but the acute diagnostic and treatment programs is unlike anything I've ever seen anyplace else. So you've come to the right place to talk about this subject.
Thank you. Yeah, I would also love to hear from the audience afterward, or if we don't have time, feel free to reach out to me. I would love to discuss more on those topics because like John pointed out, MD Anderson is definitely the place here, since it's not just about treating the cancer itself, but also on all different aspects. How can we understand those questions in more granular ways? Okay. So here's an example of the questionnaires that usually clinicians use. This is the working alliance inventories. And then my methodology that I approach is to basically do inference in real time. So here is a 10-level transcript where, say maybe we're recording in real time and you diarize it and transcribe it. And then we have when we have the inventory statement, right? The inventory, item-wise inventory, meaning that those are the statement of the working alliance. And they also have some key tables as their scales, as a basic weighting matrix. And then we basically apply it to some deep document embedding or some type of language models. Either is fine. And then we can map them on this shared embedding space and compute their cosine similarity as some sort of inference score in a high-dimensional space. And then we can compute based on the key value weights in order to get you a working alliance scores for a particular scales. For instance, for your bond scale, task scale, or goal scale. So that is a brief overview of how it is. Usually we just do have some sort of data source from the full record of patient-doctor interaction. It can definitely also do it in real time, and you can have real-time turn-level monitoring and also have downstream tasks and interpretations. So to validate this, we analyze this Alexander Street data set. It has over 950 sessions. It has over 4 clinical conditions like anxiety, depression, schizophrenia, and suicidal patient. They have those transcripts, but unfortunately the outcome is not available. So when analyzing those different sessions, we can find different roles are different scales. Let's see if it is the case. Oh no, different roles are different conditions. The first row is in anxiety, the second row is depression, third row is schizophrenia. And the first column is the patient group, how the patients are in terms of their therapeutic alliance. And on the right, we have the therapist. And we see that the patients in the depression and anxiety, they have an overall increase in their bond scale, which is the green curve, over time, while the goal scale is pretty constant, while the schizophrenia patients are more oscillatory. And that is even more so the case in the therapeutics, in the therapist group as well. You can also find whether or not there are some disorder specific propensity of this type of working alliance scales, as shown here, as well as having more interpretable insight by doing some neurotopic modeling. So shown here on the top, we have the data which is diets in the therapist and patient. We train them all into topic models. Then we can have 10 topics, which we can then do PCA to come up with some principal topics. And afterward, to better understand what those principal topics are talking about, we can pick the top therapist turns for those principal topic and the top patient turns in terms of their scores on those topic scores. And then we can come up with something which looks like this. Well, principal topic 1 is talking about emotional state and mental health. Principal topic 2 is more about personal experience and relationship. The third is decision-making, self-reflection, and personal growth. And also the approach that usually therapists take when talking about certain principal topics. For instance, in principal topic 1, you have validation, empathy, encouragement, support, understanding. For the second one, you also have validation, but have some conflict resolution. The third one, because it's about personal growth, it's more about goal setting, planning, empowerment, scale, development, so on and so forth. And we are also exploring how to use large language models to do this type of interpretation systematically as well, so that we don't have experimenter's bias. Although you might say that you introduce something else, but that is a question for a different day. And then combining the topic model with our therapeutic alliance, shown here is indicated by whether or not there are handshake or not. The green handshake meaning that it is I think just the patient is handshake. Blue means it's the therapist, or that's the therapeutic alliance for a particular topic, so that we can correlate different topic with the therapeutic alliance in a systematic way. Shown here is an interesting plot so shown here is a temporal trajectory averaged by all the sessions. So different colors are different conditions. We have anxiety, depression, schizophrenia, and suicidal. Shown on the left, we have alliance space. Shown on the right, we have topic space. And plotting here is the patient-therapist consistency of their work alliance inference score and also topic scores. And we can see that the anxiety and depression in the first few, maybe like 20 turns, they are very similar in terms of their alliance space. But then they diverge. And suicidal cases is definitely diverging the most, especially more so the case in the task scale and the bond scale and the goal scale, basically all three scales. On the right, we have the topic scale, the topic space, and you can find similar thing. So the interesting about this plot is that that tells you that even within 10 sentences into a session, maybe we can already do a very good classification or diagnosis about your clinical condition just based on how you interact with the doctors, how the patient interact with the doctors. So that is the indication of that. And then shown here is basically if you are talking about a particular topics, if the therapist is talking about a particular topics, what will the working alliance scores look like for different patients? So then you have this type of interesting thing where if you talk about principal topic 1, the therapist, then for the depression patients, the task scale seems to be pretty beneficial, but it will be not the case for suicidal patient, and so on and so forth. And you can see this variability, and you can have actionable insights for the clinicians right away based on this type of real-time analytics. And then you can even explore. Yes. Yes.
Let me just say, our usual process here is when we reach the top of the hour to call an end to the formal session, to release people to food and family who'd like to go, but then to continue the discussion. We had a combination of my apologies bringing up topics for you, and then the electric company put us a little behind schedule. So let's say that we'll end the formal session at 3 minutes after the hour.
Okay.
If you'd like to finish up, if you're close to the end.
Okay, sounds good.
And then we'll continue the discussion.
Okay, I will speed up since hopefully in 3 minutes. So here is just to showcase different conversational personality. A particular personality of the doctor will be better matched with a particular personality type of the patients. And here is another. So here is just to apply to downstream diagnostic task on certain clinical conditions there is, and it turns out that our working alliance inference score, just based on itself, is already beating the baseline in terms of classification of these 4 classes. And here is just to have more explainable AI with neurosymbolic AI, basically how a particular predicate, meaning that those verbs and nouns are being spoken, and how can you do predictions of a similar task. And overall, I want to showcase this as a hypothetical working alliance manifold in the dialogue space, where we can map out all the historical sessions trajectory onto this high-dimensional manifold such that we can identify particular time points where, say, here is a rupture of bonds. What's going on? And then you can go back to that exact time points and to showcase, okay, that is why this rupture happens, because the doctor is saying a particular thing. And or you have a bump in your as a breakthrough event, and why is that? And you can basically go back to historical sessions and know that. And then not only that, you can also have real-time analytics as well as do future prediction on this hypothetical working alliance manifold. Say, as the start of a treatment cycle, which treatment plan I should talk about? Should I talk about family or should I talk about relationship? And then you can do prediction on this manifold to roll down the hill and then say, okay, alliance stage A is more preferable, so that's why I'm gonna go with plan A. So that will be utilizing the reinforcement learning framework I mentioned earlier to maximize working alliance as a reward. However, it is tricky because it can be a dynamic maze, right? The therapeutic landscape. Even with that, we have to find the best strategy, and those are usually entangled with the anticipated theory of mind of the patients. So here is how we can apply it to AI companion system, where the AI is given the feedback towards the therapist on what you should talk about next as an actionable item. So here is what we have earlier. We have a real-time measurement of the working alliance, as well as what topic it is currently talking about. And then we can have them as a reward in real time and train a recommendation system in real time. And here is an example of a demo system where you can input any instrument that you like, and you analyze it, you diarize it, and it will be showing you some sort of real-time annotation of how your working alliance scores are, and afterward it will be showcasing you what next topic that you should talk about, then you can give feedback to it. Here is another example of reinforcement learning can be applied for speech enhancement and spoken language understanding. This is quite useful for neck cancer patients who might suffer a loss of quality due to communication condition after their surgical operation. So I will not go into detail. And lastly, we have reinforcement learning framework. This is more for AI. How can we use psychotherapy to treat large language model to make them less toxic? And maybe I will fly through this. If you're interested, you can join me for discussion. I will go to my conclusion slides where bio-inspired AI framework is very useful. You can combine all three levels. And in digital health paradigm, how can we use shared weights for this type of generalized AI algorithm that can support both interface of therapeutic interface, support interface, and human interface for different contexts. And also, I will skip this to go to here. I'm very excited about the future of having real-time AI and how reinforcement learning can power our patient care. How can we use it to guide us for iterative data collection so that the next collection is more informative, more targeted, and have real-time analytics and strategies? And also update digital twins that we already have of each individual patient or particular disorders as a more generalized population model, and also do virtual screening as well. And those are all relevant to cancer treatment, prevention, survivorship, and cancer care. My research program, if I'm honored to join MD Anderson, have been involved in these four main components. One is real-time digital measurements. How can we build better AI companion system? And combining with my PhD on the neuroscience aspect, how can we do better neuroimaging and find neuroscience insight? And also finally, some using new technology like extended reality and even do advanced contextual robotics with deep reinforcement learning. So those are those relates to cancer care, cancer survivorship, treatment, and all different kind of things. So I will leave my slide as its contribution slides. Maybe I will just stop here for the time's sake. You can read it if you like, and feel free to ask me questions if you if you have any. Okay. Am I good on time or?
That's fantastic.
Okay, great.
What we'll do is leave this up just for a few of more seconds so people can look at it. But then we'll get back to the mosaic of faces for some discussion. The section was orderly closed, but hopefully, those who are interested, and I know a lot of us are. There's important work will stay on for top. So we're having delayed that way, and for just a touch more, Chris, do you wish to say a piece before we open it up?
Absolutely. Just first, thank you, Baihan. I think what's so amazing about your work, and I think this will be novel for lots of people, is just how much softer concepts like survivorship, quality of life, mental health, therapeutic alliance can benefit from the deep technique and data science techniques. It's a beautiful demonstration of the power in that area. So my question is about reinforcement. I am very interested in supervised learning. And one thing I've always been anxious about of reinforcement learning is instrumental conversion, especially around optimizing patient outcomes, that the algorithm could learn to produce a system that ostensibly benefited patients that didn't in reality. And I think this leads to Jono's question in the chat as well. How can we ensure these algorithms are accurate as well as safe and unbiased?
Okay. So first of all, thank you for the question. I feel like let me first rephrase the problem. So basically, reinforcement learning, since it continually learns from new input, and it can be challenging to maintain a level of robustness, right? Maybe there's some new information that can contaminate the data and so on and so forth. How can we make sure that it is safe? So first of all, I want to first do a juxtaposition with the supervised learning, where many of you are pioneering, including Chris here. So I feel like, first of all, reinforcement learning can also be trained on historical data the same way as supervised learning algorithms are. And there are very good offline reinforcement learning algorithm that can do that, and also you can also have policies. Gradient method basically can translate supervised learning algorithm into the reinforcement learning setting in very easy way. So it can maintain the same performance as supervised learning it can. But the second thing is that how do you deal with the fact that when you have new data in, whether or not it will be overwriting what was previously there. I feel like that is indeed a very challenging thing if the new data offers a new context, right? So theoretically speaking, one challenge in reinforcement learning is that out of distribution generalization. If, say, I'm trained in a particular game setting or a particular patient setting, and then the data comes in, offers me new patient interaction, but for different clinicians, and sometimes it cannot interpolate very well, extrapolate very well towards that many very doctors or new data set. So to deal with that, there are techniques. How can we basically compute some sort of propensity measure between the new data and old data, so that if the new data is very similar to the old data, it will have a larger weight, which we call important sampling, so that the model is more robust towards already pre-seen scenario in the state space, right? Because in medical setting, like mentioned earlier, the decision can be highly combinatorial, so that the state space, there is curse of dimensionality, where you cannot overall cover the whole space. So the way to go forward is to tread carefully to use this type of important sampling approach, so that if it is too far away from the previous trend scenario, it will have a less weight, so that it learns in a smaller step, so that it's actually more safely to deal with like unseen cases. And then another case about good reinforcement learning is that you can use human moderation very easily. So as in showing the system there, it's doing prediction, but a clinician can also correct it in real time. So such correction as an actual feedback loop can also make the data to be basically human in the loop correction, to make the model to be more safe and align with the values that we wanted to exemplify, especially in healthcare setting.
So we can assess it in a very similar way. It's a training process.
Yeah. As in, this Sander do a couple interesting comments in chat about timescales and cycles. I think that fits in nicely with what you just saying by him about an evolution in general. Yes. Sander, there, you're weird if you kind of to say something. Going once.
Hey, the questions reading the time scale. What about the time scale reinforcement learning? The single cycle sequence to lose time.
Yeah. Yeah, so that's actually a very good question, right? So when we are thinking about reinforcement learning, indeed, many of the past application has been like game playing or robotic control, where it appears that you have to train it forever, right? So like AlphaGo, the first version, it takes like training for 3 months to do that. Obviously, in a healthcare setting, we don't have that luxury, and also we don't have that amount of data to do those virtual simulation. But luckily for us, nowadays, the therapeutic work of reinforcement learning has already marched towards a phase where we can train on the historical data we already have. It doesn't have to be one cycle. It can be just trained on the historical data as some sort of even foundations, right? If we have many of the learned representation to be shared, and afterward fine-tune it to particular tasks. For instance, maybe I train a very good like patient support system for say palliative care department, but different clinicians, they have their own different styles, and maybe they want to do something different. Then you can still use that model and fine-tune it yourself. And for that, since you already learned for the overarching task previously, you can do a very few shot learning in that sense, because those models are already flexible to adapt to a slightly different cases for personalization. Yeah.
David, Jeff, you want to say something about the tremendous enterprise of developing information base in the context engine and related areas.
Oh, yeah, it's very exciting. I had really enjoyed the presentation of the high-level perspective of learning health systems paradigm, but also that sort of all these new data science methods to really shift to thinking from the traditional Institute of Medicine paradigm that's been out there for, it's going to push, I think, 30 years before it's alone. So really transforming the way we think about, cognitive science and health. And something that our huge effort here, of course, is to get data flowing, as we've spoken and several times by how so that wiring in the low-cost measurements, et cetera, as a mechanism to inform this, I think is super intriguing. That would be an area that, learning how to measure things maybe that we haven't already decided we need. So this sort of data-driven paradigm in science versus the empirical, the theoretical, the computational, but now a wealth of data that we can pour over to explore insights. Any thoughts on optimal measurement in these contexts?
You mean like optimal measurement of optimal measurements of what type of measurement to use, or optimal measurement of patient?
Well, I mean, I know that there's a dialogue around how much we could ask a patient to give us information.
Yeah.
So this seems like an opportunity to assist with that.
Yeah, I would definitely agree with that. So I remember Chris used to do a lot of Dr. Chris Gibbons used to do pioneering work on basically like computationally optimized for the questionnaire, right? So basically his research has been pioneering how you can ask fewer questions to get the same amount of informative thing. Then I can also think about similar approach where basically you're considering yourself doing like a 20-hand man, right? So you are trying to figure out a particular thing with the minimum amount of information that you might have. So that can actually be done with reinforcement learning algorithm pretty effectively. I feel like a different approach would, instead of training it as a dueling agent, you are also having this type of, so one argument that I make in my slide is that this reinforcement learning are very good mechanistic model, digital twins of how patient will respond. So in a sense that maybe I can just ask the question offline through towards the digital version of the patient and tries to basically mimic the interaction and see which version of conversation do I like the most? Which one of conversation is the most efficient? So that is actually an active field of research that I previously also have worked with in Amazon, which is a conversational recommendation system, right? So in their end, they have a similar issue where they want to ask the minimum amount of questions for customer support, and they don't want to ask too many of them. Otherwise, the users will be unhappy about them. And similar things is that reinforcement learning is actually a powering engine for their type of conversational recommendation system. So instead of just recommending an action, you are recommending what to say, what questions that you are saying, and binding with existing work on GPT and other things, which is one thing that I'm currently doing in the psychotherapy setting. We not only recommend action, but also personalize it into what the clinician is actually saying, will be also an interesting way to think about, so that if we want our patient to be in the intake side to interact with this chatbot like agent and to get their information. Yeah.
I see Jeff Chin from the NLP program. Any thoughts about the aspect of this overall project? Center project? Yeah, we really engaged.
Yeah, I think this is a very we bring lots of exciting new technology and new paradigm to the research, and it will be so exciting for our health, for our institution.
Miss out any trenchant comments and the drug discoveries.
Have you used it been said? Yeah, I was blown away honestly by Han, and I have to say I took such precedence through saying this is just so space age for me. Like, I really appreciate some of the stuff that you're showing us. One thing I'm particularly interested in is, as I've called the people of things, is pediatric oncology. So we have a great success rate in theory, in that, it's about 70% of pediatric patients get full heal, basically. But as you probably know, the developmental side effect of the therapies that we're currently giving them are just awful. So 2 parts to my question. The first one is, what do you think major differences would be when you're trying to apply this kind of thinking to pediatrics? And secondly, how far back can we start applying it? Could we somehow marry it up with the therapy that we're doing and the monitoring during the therapy in order to minimize the developmental side effects that
Yeah. Yeah, thank you for the question. So actually, for myself, I'm especially interested in pediatrics and care. So last week I have the pleasure to meet with many amazing individuals in MD Anderson in Houston physically. Thanks for Chris and also the organizational team. So among which I actually get a chance to actually chat with Dr. Richard Gordick from the pediatric division. So I'm deeply interested in pediatric questions, and I have worked with individuals ranging from children with cerebral palsy towards adolescents at risk for psychosis, schizophrenia, and also other medical complexities. So I feel like indeed there are many differences of how we deal with pediatric oncology versus the adult oncology. One thing is this like family-based approach. I'm actually very intrigued in not just dealing with the patient itself, since now we are treating them basically as a family, as a unit. So in a sense that how are the parents are also handling, and also how are the parents interacting with the doctors, how are the interaction between the patient and the parents. It's actually my area of interest, which I have shown in my collaboration with Mount Sinai, that it is indeed the case that doctors' interaction with their parents is highly correlated with the patient outcome of how their adolescent children are responding to a particular therapies with the same therapy. And I feel like it is especially the case for our line of work is especially needed for pediatric oncology, since I was reading this cancer survivorship study recommended by Richard like last week, how basically parents of the cancers, the kids with cancers, they are 95% of them, they will have a divorce. No matter whether the children are treated fully cured or not. So those psychological issues are definitely there, and I believe that those are very important aspects. And with respect to the developmental disorders that you are mentioning, how perhaps many of the patients there during their developmental phases, they have different cycles of treatment. How do you deal with developmental trigger? So I would definitely see that those would need additional research for me to understand the context, since I would imagine those developmental trajectory to be different from normal kids when they are developing across their lifespan. They have different area of focus, so it will be needing more user research to talk with the patients and to understand what are the main focus of the developmental disorders there for us to pay more attention to. Yeah.
And then, so Susan, you have your Everest for a while. The silent here, not through, didn't mean to cut you off.
It is saying amazing. Thank you.
Thanks, Faisal.
So a great presentation. So my question, kind of building on to the prior question, but kind of taking it more a little bit different.
How about, including like social determinant of health, because I was looking at it, listening to you a lot, and, especially in the space I look at is looking more at the minority population, and just, well, not necessarily this minority, but just looking at social determinants of health. How do you incorporate that into your model when you're doing a digital twin?
Okay, so let me rephrase your question. So if I miss any part, feel free to let me know. So the question is that how do we deal with the fact that can we make our model to be more accessible and fair, so that it can also deal with the fact that there are minorities, but minorities are usually less dominant in the training data set that we have available, and maybe that they also don't have like enough following up, so that we also temporarily don't have as many data points, but still we also want our model to be resilient in that aspect. So I have done a few research on basically this type of cognitive inference of psychological property, how to best approach them. So I write a guideline of that on the ethical and operational consideration. So that is definitely a very important thing. We don't want our model to have innate bias on those things. So there are several things to consider. First, I would assume those data sets, not only just existing data sets that we can pre-train upon, and when we are collecting them, we take into account those things. So not just an afterthought for us to analyze the data, but when we are collecting data, we work with the clinician to make sure that they are well represented in the first place. And second, algorithmically speaking, if we are considering put on our engineer hat, there are many approaches to do the debiasing, right? So we can basically train the model in particular way. There are some sampling approach. There are also some adversarial approach to correct for the innate bias if it is not well represented in particular application. It is actually quite interesting because I read similar work where those psychotherapy data which are usually collected from Hakushan patients are not well established towards, say, African American population because sometimes people talk in different styles. Maybe even in the Western culture and Oriental culture. Western culture, people are more expressive of their feeling, but in Eastern culture, sometimes we will be more suppressing our feeling, and sometimes we want to rationalize it more than expressing explicitly emotional thing. So I would think for those things, it will require some finer specificity. For instance, we will need to train fine-tune models on an existing data set on different population of the patients, and then those model itself will be more suitable to the need of their own. And also constantly in each iteration to cross-evaluate those performance across different matrix so that we make sure that we're not putting too much emphasis on the dominant group versus another one.
The Baihan, aren't those then just digital twins then? To fine-tune.
Yeah, so they could be population-wise digital twins in that sense, right? Or it doesn't have to be digital twin, because when we talk about digital twins, we are talking about those things are mechanistic models of how these patients are saying or how these bodies will respond. But here we are also talking about AI companion, which is a slightly different thing from digital twins. They can also be powered by reinforcement learning, but they are kind of like not digital twins of a human being, but kind of like an intelligent being of itself, like a consultant or whatever thing there. Yeah.
You showed the Go board very briefly, and I'm fascinated by Go and by what's happened in the Alpha Zero school adversarial learning. And just trying to think whether if you have templates of, let's say, what a good psychiatric session looks like, something more detailed than simply is it good or bad, or did solve this or what problem. Anyway, is there enough data in place as a starting point for adversarial approach to these issues?
Yeah, I feel like if we want to train a particular model for like psychotherapy, right? Mm-hmm. So there are certain challenges over there because like public data set available there it usually don't have clinical outcome, right? So in order to do that, because I'm now training large language models for psychotherapy setting per se, and one challenge is that we don't have labels to know what is good. Although they are all experienced therapists, but having some negative example is quite important. So as a result, one thing operationally would be to hire colleagues to annotate them for us. Another way would be to have, say, some sort of negative examples where hopefully there are also public data set from not so well clinicians, right? So for instance, you have a friends to do that, so that at least you can have so what do we call contrastive training, right? So we have know what is bad, what is good, and then we can train them effectively to know what is good. And then for the language model inside, after which, when we have a score, we can then place a tag onto them so that you can do reward learning for this type of chatbot setting. So actually, now that you're thinking, so one approach, I did have this approach. I can use my therapeutic alliance, which is basically a criteria to evaluate whether certain conversation is good or not in terms of the patient-doctor relationship. So I could just use that score, summarize it, and ask a reward feedback, so that, which is what I'm currently training for the AI companion. And that is already giving us a very good thing to evaluate whether a session is good or bad.
The referee effect begins in the opening. In assist. Well, I think we really want to present, but there's someone who has this flipping up in it who would like to comment or ask a question before we do close. Please raise your hand and we'll just speak out. Well, I think we got into the point in which we should really release people to friends and family and therapeutic beverages, so I really, where is it going to find us? Those bits, and by online, that makes you recognize for sure how it inciting the thoughts into your whole brain, back to our attention. This is further around the kinds of things that you're most interested in, and for accumulation of the kinds of data that are necessary. The son has the last word by clapping their hands and how that too, and I'm sure you'll be a lot work. I will be in touch with you. I questions about some relationships to evolutionary processes, but not for evolutionary processes that you brought up excessively and explicitly and several other topics, but I'll save those. So,
And happy very much, right?
Yeah, I would love to hear that. Yeah, I just want to say that it has been a pleasure to meet many of you like last week in person. So I would love to actually discuss more those exciting topics with basically all of you. Yeah, more. Yeah.
So much.
Thank you.
Bye.
Hi. Have a great day.